All right, so let's talk about hyperosmolar hyperglycemic state, or HHS. I find that DKA, the diabetic ketoacidosis that we talked about last week when we talked about diabetes type 1, and HHS tend to be really difficult concepts in nursing school because everything is so abstract. You haven't necessarily seen anyone in DKA. You haven't seen anyone in HHS. So it feels like it's just memorization at this point. So what I tried to do is I tried to break it down. I don't know, it's just the way I think about it. Now that I've had a little bit of experience and I've seen this happen in real life, it makes a lot more sense. So I tried to use that in trying to explain it. Hopefully it will help. If not, shoot me an email and ask your questions and I'll try to do a better job. So when we talked about diabetic ketoacidosis, we talked about what kind of begins that off. And the big kicker at the very, very beginning was that we had absolutely no insulin left in the body. So the body was making a very little bit of insulin. And now something happened, whether it's I went for a run or I got sick or whatever caused the glucose in my body to rise to the point where it used up all the insulin that I can make. So this kind of square, when we're talking about diabetic ketoacidosis, is absolute insulin deficiency. When we're talking about HHS, we're talking about a relative insulin deficit. And that's because the diabetic type 2 is still making a decent amount of insulin. In a diabetic type 1, it's more serious in that it's more of a chance that that person is not making any or making very, very low amounts of insulin. Usually with a diabetic type 2, you're making enough insulin that you never hit that spot where you have none. But you might hit that spot where you have so little that you're actually going to go into this kind of high risk situation, and we'll walk through. How does that happen? Very, very often, people will forget to take their meds, or some type 2 diabetics who are on insulin, although we try not to put type 2 diabetics on insulin. Technically, insulin, if you look at a list that kind of like compares diabetes 1 and diabetes 2, all diabetes type 1 are on insulin. It's a must. They have to be on insulin. And so oftentimes when they go into DK, it's because they've taken too much insulin. So with a diabetic type 2, you know, some of them definitely are on insulin. In fact, probably the ones that you're going to see if you're in acute care are on insulin, because there's a reason they're in acute care, right? So yes, it can be a problem with insulin. Newer insulin resistance, again, non-adherence to insulin treatment, which is what I was just talking about. So that's kind of things that deplete insulin. But then you also have things that can increase glucose. When you increase glucose, your body has to do something with that glucose, and the only way for it to do something with that glucose is through insulin. The only way for it to do as much as what it needs to do is through insulin. It needs that insulin to get into the skeletal muscle to deal with whatever it is that's caused this increase. And it needs the insulin to direct itself to the liver to be stored. Without it, you're getting this giant buildup in the blood. I know I'm repeating myself, but it's good to say these things over and over and over again. You won't miss it on the test. So what kinds of things can cause an increase in glucose? Sometimes just like extreme stress, anything that will increase the insulin demand, in other words, increase the glucose, infections, and anything that your body is fighting like this, it's going to have an SNS response, and part of that SNS response is getting as much glucose out into the body because it's preparing to fight. So part of what that does is it's going to take some of that glycogen that's in your liver, and it's going to break it back up into glucose and send it out into your blood. And so you have to have something to do with that glucose, or it's just going to build up. And so because there's some glucose, some of it will be taken up by the muscle and the fat cells, and some of it will remain in the blood. Let's go this way first and talk about what happens with the actual glucose in the blood. Obviously, you're going to end up with hyperglycemia. In fact, in HHS, usually patients will have a much higher blood glucose than they do in DKA. I think a part of that is that the symptoms of diabetic ketoacidosis are so unlivable that people come in a lot earlier. They're usually very shocking symptoms. You've got the polyuria, polydipsy, polyaphasia, and then the very dry, and that acidosis feels terrible. You look terrible, you feel terrible. People tend to come in a lot earlier before their blood glucose hits quite high. That being said, I've definitely seen people come in to emerge in DKA with a CBG off the chart that's unreadable, or a urine dip CBG that's unreadable, or whatever. It gets quite high. But typically your hyperosmolar hyperglycemia is going to have a higher glucose. When you have high glucose, hyperglycemia, right? You have so much going on. There's so much glucose in your system, again, because of gluconeogenesis, which we talked about over here. And we have so much. Normally, the kidneys actually reabsorb quite a bit of your glucose. So in the proximal tubule, when the glucose comes down, when the fluids come down, most of the glucose that comes down is actually reabsorbed back into the blood. But once it gets to be the point where there's just so much, the kidneys can only reabsorb so much. And what happens is you actually end up with this glycosuria. In other words, glucose in the urine. So you'll do a urine dip and you'll actually see glucose in that. As on top of that, we talked about this with DKA, so I'm not going to go through it ad nauseum, but you can go back and take a look at it. And remember that glucose molecules themselves are quite large. They're quite large proteins. And remember we talked about when we talked about fluid and electrolytes, and that fluid and electrolyte shift, and how the larger molecules tend to pull fluids towards them. Right? We talk about that when we talk about albumin a lot of times, how when that albumin gets out, it pulls the blood into the interstitial spaces and fluids, and so on. Well, some very similar thing is happening here. And in fact, it happens in diabetic ketoacidosis as well. There's a little difference, and we'll talk about it. But so because you have all of that glucose in your fluids, so we're talking about the amount of glucose that has been reabsorbed, which is very high, right? Some of it has gone out in the urine, which is not supposed to happen. So that's a sign right there when you see, oh, there's glucose in the urine. But the rest of that glucose that's gone back into the blood, it's going to pull fluids. In other words, it's going to cause osmotic diuresis. It's going to cause, it's going to change the osmotic gradient, meaning it's going to pull fluid out of the interstitial space, and maybe even intercellular, but definitely interstitial space, and into the vascular system or into the blood. That blood is then going to go to the kidney, and it's going to be filtered, and it's going to come out as urine. And that's why you have polyuria. You will have the same thing with diabetic ketoacidosis. it really depends on how much glucose is in your system and how well your body is dealing with it. But that is where that polyuria will come from. Now you've had polyuria, meaning you've been urinating and urinating and urinating. So of course you're going to end up with dehydration. When you come in with HHS, you can have quite severe dehydration, which is going to, of course, alter the total body water, and your ion and the shifting osmosis, and all of this that's going on is all it's just saying is it's going to have some kind of effect on your electrolytes. Your electrolytes are going to go a little wackadoo. And you're going to have the same kind of story here that we had last time with your potassium, where that potassium is pulled out of the cells, and your serum potassium is going to be probably very high when the patient first comes in. It might be high or normal, but you still have to give potassium because that potassium that has been pulled out of the cell. Remember, potassium lives in the cells. Most of the potassium in your body is in the cells. It's your sodium that's in the fluids outside. And so when we pull all of that K out, because remember that glucose, right? And there's some stuff going on with hydrogen and what have you, but we're not going to go into all of that. Basically, it's pulling that glucose out of the cell. Now it's in the blood system, right? It's no longer in the cell. That's not good because we need it there. But also we've got higher than normal inside. And so sometimes a patient will come in and their potassium will be, 5, 5.3, even 4.9. Sometimes it'll be quite high, it might be a 6.2 or something. And you're still getting potassium ready, because what's going to happen is we've got this whole polyuria osmotic diuresis thing going on. So all of that urine, all of this fluid is getting filtered in the kidneys and then coming out in your urine. And what's happening to that potassium that's been pulled out of the cell is going into your urine. And very, very quickly, you're going to go from these numbers here to hypokalemia, which we know is extremely dangerous. So potassium is actually the third thing that we're going to deal with in our emergency treatments of HHS and DKA. This is a really, really important concept. And I'll tell you guys, I did not get this in nursing school. I didn't even get it the first time I saw it in Emerge. It was actually one of my first days on my own on a patient with DKA. And I obviously asked for help because it's a very serious situation and I'd never dealt with that before. And I remember them prepping the potassium, and I'm looking at the blood work, and I think their potassium was they were hyperkalemic. And I was thinking, what is going on? And of course, I'm never, ever scared to ask questions at work. And so I asked, and after, when things were a little calmer and the patient was doing well, I asked, and still didn't quite understand what the nurse that I was working with told me. And it wasn't until I came home and kind of worked through it on my own that it made sense. And this is how I made sense of it. So hopefully that helps you a little bit as well. So that's kind of one side of things. Let's talk about what else is happening because of this. Again, this increase, we've got this increase in glucose going on, and or this decrease in insulin going on. And so you do have some, again, we've talked about this, we have some insulin present, but it's not enough. And so the cells are not getting the glucose. So you've got a ton of glucose in the blood, but the cells themselves are not getting any glucose. And the body thinks, I need more energy. These cells are not able to metabolize, right? They're not releasing energy. They're going to die if they don't get glucose. And so the body thinks, we need more glucose. We don't have enough glucose. And so it starts to release those counter-regulatory hormones. Counter-regulatory because they work against insulin. Again, check back in the other video if that's confusing to you. So it's going to release those lovely things as glucagon, epinephrine, cortisol, and growth hormone. Likely if your increase in glucose is because of a stress response, you already have a bit of cortisol going on in your blood. You're going to have even, or in your system, you're going to have even more going on. All of these things here are going to increase the glucose. The body doesn't understand at this point that the reason the cells aren't getting glucose is because they don't have insulin to let them into the cell. It just thinks we're having a glucose depletion and we need to make more. So how is it going to do that? It's going to do it through, if you look back, it's going to do it through glycogenolysis, which breaking up in the liver, it's going to break up glycogen, send it back out into the blood system. It's going to create new glucose in the liver as well. And so the body tries to increase blood glucose in an attempt to increase the cellular absorption of that glucose right here. So what happens, again, an increase in gluconeogenesis and glycogenolysis, and a decrease in protein synthesis. And that's because it's trying to pull some of that glucose that has been stored in the muscle. Remember, we said you can go back to the very first video when we talk about diabetes, and it talks about what's going on with the glucose and the protein in the muscle. So go back and check that out if that's a little bit confusing to you. And then again, I just want to go up before we go down to the confusing part. This is the easy stuff. The hypothalamus senses that low intracellular glucose, right? We don't have enough glucose, and it's going to trigger a feeling of hunger. It's going to do, of course, it's going to start to create as much as it can from what's inside the body, but it's going to say, like, give me some more glucose, eat some food, right? And so it's like, eat a cookie, and it's making you hungry. And that's where you get that third P, which is the polyphagia. So what's really, really, really important here is that in DKA, remember when we get to the point where the body has no insulin at all, and it starts to break down lipocytes or fat cells for energy. It's called lipolysis, remember? Because in HHS there is still some insulin, the body does not break down lipolysis. Insulin, it's not because the body is still triggered to break down fats. It thinks it doesn't have enough glucose, and so it's going to go after those fat cells and try to break them down. But one of insulin's jobs is to stop lipolysis. And because there is some insulin, it does its job there, and it stops the breakdown of fats in your body. And so because of that, you don't have that release of ketones. And that's why we don't call this ketoacidosis. We call this something else because of what I'm about to explain. But this right here is really, really important to understand for a test, for life, for everything. So just make sure you get a hold of that. So then that's why we don't call it ketoacidosis. Why do we call it hyperosmolar, right? We've kind of hit on it a little bit already. I'm going to look down here at this severe dehydration. Remember how that happened? We had all that glucose in the fluid, and the glucose are big, big molecules that are pulling the fluids out of the blood. And now you've got this polyuria, and you've basically urinated all of or diuresed is probably a better way to say that. You diurese all of or a lot of your fluids out, and now you have severe, severe dehydration. If the patient is conscious and water is accessible, they will have very severe polydipsia, which is the second P, right? Polyuria, polydipsia, polyphagia, which is over here somewhere, right there. Whoops, sorry, still learning. And so that's, it's actually a really good thing. They may be able to stave off what I'm about to talk about, which is the worst part of the hyperosmolar. So if the patient is not alert or doesn't drink enough water, they're not replenishing the fluid volume that's lost over here. They're not able to replenish it. And so now you have a huge decrease in extracellular fluid volume. In other words, you're severely hypovolemic. What happens to the osmolarity of a substance when the fluid that it's in goes down? If you have a lot of fluid and you have 5, 6, 7, 8, 9, say 10 osmol, I don't know if that's even 10, that many osmols, that's how spread out the particles are. If you have this much water, this much fluid, and you still have the same amount, you see how much closer they are, right? And this is where that osmolarity or that hyperosmolarity of HHS is coming from. It's this whole thing that's happening as well in DKA, this polyuria, polydipsia, severe dehydration. But, excuse me, here the patient is not replenishing that. The glucose, because remember we said that glucose is so much higher in HHS than it is in DKA. So DKA at this point has probably been treated or start being treated. By the time a person with HHS comes in, their hyperosmolarity is so bad that the extracellular fluid begins to pull fluids out of the cells. It pulls fluids, and especially out of neurons, and the neurons begin to shrink. And what actually happens here, and there's a reason I drew this giant little, hunky-do around this, because this is like your hallmark symptom. This is the thing that's going to tell you on a test that we're talking about HHS and not DKA. And that is because of all that fluid that's being pulled out of the neurons, you have fairly severe neural damage. And you will have delirium and lethargy. But it actually can look like a seizure. You can have hemiparesis, stupor, like all of the things that you might think of seeing in a stroke, you may see in HHS. You will see some, decrease in the level of consciousness in somebody who's in DKA, but it's not this kind of neural damage. And so really that's the big, and this is why we call it hyperosmolar hyperglycemic, because the problem here, the most scary part is this hyperosmolality and what it's doing to the body. One of the other things, just really quickly, that it does as well, if you've got low ECF, low extracellular fluid volume, when that fluid hits your kidney, the kidney triggers, it knows it's not getting enough, right? And so that low renal perfusion, it's going to decrease your GFR. If you don't know what that is, don't worry. There's a video on kidney disease and GFR somewhere in here as well. And it becomes a pre-renal cause of acute kidney injury, meaning because of all this that's going on, the dehydration and what have you, the kidney is not being perfused, but it's also being used like crazy because of all this polyuria, right? And so someone will go into renal failure very, very quickly. And of course, you're going to have an increase in your electrolyte imbalance. So just really, really quickly before we go on, I want to actually, let's talk about the management first quickly, and then I want to compare the two, DKA and HHS, one more time, just so that you get everything and you don't miss this on a test. Definitely going to show up. So when we're managing HHS, very, very similar to DKA. What's the big difference here? Well, we talked over here about we don't have that lipolysis. So we don't have the breakdown of fat. We don't have the keto acids. We don't have the ketoacidosis. If you're confused about this, check the last video on, there's a huge chunk on DKA, kind of goes through it exactly like this. But because we don't have that, we don't have the acidosis to treat. So that's really the big difference. Otherwise, we're in the same story. ABCs always, guys. God, I can't tell you how many times when I'm doing NCLEX prep that people miss the most simple questions because they're thinking They're thinking so far beyond on what's going on with the hyperosmolality, blah, 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 blah. And meanwhile, like the patient's not breathing. So oxygen, right? Like if this is not, it's not, it shouldn't be brain surgery. Just don't forget about your ABCs. They're so important. You still have to prioritize, right? And I know that's hard because you're thinking about all these things all at once, and then you've got to try to figure out what the test wants, and there's definitely going to be more than one right answer. I am hoping to make, just side note, I am hoping to make some videos on like how to answer these questions, how to read them, how to think through them. So hopefully I'll be able to get that up by the end of the summer. So anyway, first thing, ABCs, same thing with DKA. Second thing, fluids. So you would think, and this is something that people run into all the time during test questions is, well, the problem is we're hyperglycemic. Like, shouldn't we be giving insulin first? Isn't that the most important thing? It's actually not. The highest risk at this point when a patient comes in this acute HHS or DKA, the most dangerous thing is the dehydration. So fluids first. Don't worry about my spelling error. I'll fix that later. Sorry. They will obviously require more fluids for DKA, right? Because they have more of that glucose in their body. They've had more fluid pulled out and more polyuria. So we need to give them a ton. Make sure you're watching out for your decrease in potassium if you're giving fluids, right? Because you're probably going to diurese some of it out. Usually we don't actually discontinue when the BP stabilizes. We usually leave that in until the patient is drinking on their own, but always know this, so important. Can't emphasize enough. 30 mils an hour urine output is normal-ish. We don't want anything less than that. 30 to 50 is really like a good safe zone. This is a little bit different than DKA. So as the fluid is, because we have this issue with the neural damage, we want to make sure that as we're giving fluids, there isn't this giant shift of fluid back into the brain, because you will increase the intracranial pressure. So you just have to keep an eye on that. And then your second, or I guess your third, if you're counting your ABCs, your third thing would be your insulin. You give a bolus first, and then a continuous infusion. Don't worry, there will be an order, and there will be a lot of people around. You won't be doing it by yourself. Fourth thing we're going to look at is potassium. Probably going to administer potassium. It may be 5.5 when they get there, but you will take blood work constantly. Throughout this whole process, you'll be doing blood probably Q1, and you will see this start to drop usually, and we'll have to have that KCL ready. And then, sorry, it's potassium chloride. And then, of course, you got your prevent further complications in your patient teaching, which I know none of you guys will have a problem answering. So really, really quickly, this is the treatment order. ABCs, dehydration, hyperglycemia, hypokalemia. In DKA, we have something right. Actually, I think it's here. No, sorry, here, where we want to deal with the acidosis as well, right? Well, it's in the other video, so you can go take a look at that. What are we going to monitor the whole time? Same thing as in DKA. Vitals, levels of consciousness, LOC, really, really important because of everything that's going on with the neural function. They're going to be on tele. They're going to be on O2 sat. They're going to be catheterized. You're going to be measuring everything that goes in and out. Breath sounds, because we're giving fluids. Whenever you're giving fluids, your test, pay attention, because test questions, it throws you off because you know that you're dealing with dehydration. Why do you care about listening to the lungs? Well, you have to think about the treatment too. You're giving so much fluids. We don't want fluid overload to happen. So you have to be listening to breath sounds, watching out for that. And then you will be doing your glucose and potassium levels constantly until that person is back into some semblance of being able to function on their own.